Good morning, ladies and gentlemen. My name is Ilya Kokotkin, and I'm one of the fourth-year medical students in St. George's University Hospital, and I've done this research as part of my course under the supervision of Dr. Demustis, who is currently here. So, Oasis is greatly associated with anal incontinence in postpartum women. Apart from carrying great physical harm, it's also associated with the high financial burden. Although certain risk factors of Oasis are greatly established, the role of one of the most commonly performed surgical procedures during labor, episiotomy, remains somewhat inconclusive. Although there is definitely some association between episiotomy and rates of Oasis, there is evidence suggesting that episiotomy can be a risk factor of Oasis during vaginal delivery and a protective factor. So the aim of our study was to establish the impact of episiotomy on rates of Oasis. This was a retrospective study with the data over 10 years. Almost 30,000 vaginal births were included, and the multivariate analysis was employed to control for 13 various maternal, labor, and fetal characteristics. Overall, there was 1,291 cases of Oasis. The rates of Oasis increased slightly from 3.47% in 2008 to 5.37% in 2017. While the rates of episiotomy remained relatively the same. Most of the vaginal births were non-instrumental, and there was an association between the reduction in the rates of Oasis and use of episiotomy in the forceps delivery, where we can demonstrate that the incidence of Oasis was greatly reduced in episiotomy cases, although the same thing was not evident for non-instrumental and venous or vacuum deliveries. Overall, our results demonstrated that the use of episiotomy was associated with a lower odds ratios of sustaining Oasis, and especially it was evident in forceps delivery. However, it was not statistically significant for venous and non-instrumental deliveries. Our study was in agreement with some previously published evidence, and the conclusion was that our results indicated that episiotomy in forceps-assisted delivery is protective against Oasis. However, episiotomy probably should be used very restrictively in venous and non-instrumental deliveries. Thank you very much.
Are there any questions?
Thank you very much. I have two questions, if that's allowed. The first one is, how do you explain the fact that in your study there is no protective effect of mediolateral episiotomies in venous deliveries, whereas in most other studies there is a clear protective effect?
That's a good question, and I think that was also the surprising finding for us. I think it warrants further research into the cause. There could be multiple causes for that. However, I think it would just require more research into maybe there's some other risk factors, maybe there's some selective bias towards venous delivery, maybe because when it's, as in our national guidelines, it's used as a first type of instrument. Potentially there could be something into that, something behind that.
My second question is, how do you counsel women before a forceps delivery that they have a chance of 1 in 7 to sustain a sphincter injury, with, in the long run, about a 1 in 10 risk of becoming having anal incontinence? How do you counsel these women before you do a forceps delivery?
I think based on our results of our study, we could say that if the forceps would be required to be used in the deliveries, we can say that the episiotomy will be performed, because from those results it's indicated that it will reduce the risks.
But still, it's 17%.
Yeah. I think that Dr. Demustis can't answer on the clinical side because I'm just a student. Sorry.
I ought to answer these questions because as the clinician, my medical student does not have exposure to the shop floor. So with regards to the first question, my inference in that is that we tend to do more perineal guarding when we do ventouse deliveries. We practice mostly kiwi deliveries, and we keep a hand on the perineum either consciously or subconsciously in most cases. And this probably explains the protective effect of this maneuver when we have a standardized approach on the performing vacuum deliveries, as opposed to forceps, where sometimes needing to have two hands with the maneuvers of forceps is not always easy to have one hand on the perineum. This is, I hope that covers the question, but this is my only explanation I can give for that. Not all vacuum deliveries are with the same device, but in our institution, the vast majority, if not all of them, are with kiwi. The second question about counseling is a very challenging aspect when, especially in emergencies, and the tendency is in emergency deliveries, we tend to have a preference for forceps because this encourages more speed of delivery to go on a full counseling about long-term factors of fecal incontinence. This type of discussion should take place in the antenatal setting. But again, during labor, during an intrapartum course, you're on a catch-22 when you have to act rapidly, make rapid decisions, get the patient engaged, and sometimes there is not enough time for a complete counseling, I'm afraid.
Well, we're not here for discussion, but I would still suggest for the people from the UK to look to the people from the continent, where many countries have obstetrics with virtually no forceps deliveries and still good results.
Do we have time? Okay. Ida Bergman from Stockholm, Sweden. Thank you for a lovely presentation. I have a question about your power calculation, because Oasis is still relatively uncommon and you need a lot of power to detect differences between the groups. Did your, I'm mostly interested in the vacuum because we do only vacuum, Did you have enough power to detect differences in the vacuum group?
So, as far as my competence, when I've done research, that the power is mostly calculated for prospective randomized trials. So, because our research was mostly based on the clinically recorded data, so we had all the data we had is all the data we had, and so we had to work with that. But comparing to the other studies that performed on a similar matter, the number of the cases and number of women would indicate quite a large sample. I hope that answers somehow.
A very short comment. In this case, we account for the differences, so the type of regression we use accounts for the very low incidence of some of the groups. So it's not strictly speaking about power calculation, but it's about adjusting the statistical analysis to factor it in.
That's true.
Thank you.
Thank you.
Thank you.